Welcome to updates on the Temozolomide trial for SDH-deficient GIST patients. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services, and I am your moderator for today. I would like to introduce our presenter today, Dr. Jason Sicklick, who is a general surgeon and surgical oncologist who specializes in treating hepatobiliary diseases and sarcomas, including gastrointestinal stromal tumors. He has a special interest in abdominal and retroperitoneal sarcomas, primary liver tumors, and colorectal and neuroendocrine cancers that have metastasized to the liver. We have a great presentation today, and I'd like to transfer over now to Dr. Jason Sicklick to begin.
Thanks, Sarah. Good morning, good afternoon, good evening, depending upon where you are. First, let me apologize for having to reschedule this from a couple weeks ago. I had to emergently take somebody to the operating room. It's the other hat I wear. So with that, I want to get started since I know time is limited and there's a lot of ground to cover here. So we're going to talk about the Temozolomide trial for SDH-deficient GIST patients here at UC San Diego, and the approach that we came to this trial. So by way of disclosures, you can see here I have research funding from Foundation Medicine, Novartis, and Amgen, and have received consultant fees from Loxo, Grand Rounds, and Decipher. So the agenda for today, we're going to start off just giving some basics about SDH-deficient GIST, and then we'll move on to what is known about previous treatments for SDH-deficient GIST, and then the science behind temozolomide and how that's now been translated into a clinical trial for SDH-deficient GIST patients. So just as a reminder, which probably most people already know, GIST is a tumor that arises from the interstitial cells of Cajal, or the pacemaker cells of the GI tract. These tumors occur within the wall of the bowel, most often the stomach, and are marked by overexpression of DOG1 and c-KIT, or CD117. The incidence around the world is somewhat variable. It's somewhere between about 3 to 7 cases per million people in the United States, all the way up to about 17 to 20 cases per million in Asia. The peak incidence is generally in the 70s, but with a mean age or average age in the mid-60s. As I mentioned before, GIST can occur anywhere through the GI tract, including the esophagus, stomach, duodenum, the remainder of the small intestine, the colon, or the rectum. But the most common place is the stomach, and for those patients with SDH-deficient GIST, essentially all of those tumors occur in the stomach, with the exception of one reported case in the small intestine. So the focus of today is going to be on the SDH-deficient GIST population, which are tumors that represent about 5 to 10% of all cases of GIST. These tumors tend to have a histology, or when they look under the microscope, they have what's described as an epithelioid appearance, and they have lax staining for the SDHB protein, as we'll talk about. So just some additional information about SDH, or succinate dehydrogenase. So if we start off, we need to look at the cell itself. And within the cell, there's a structure called the mitochondria, or the mitochondrion. And this is essentially the energy workhouse of the cell. The mitochondrian's job is basically to convert sugar into energy. And it's through this process called the Krebs cycle that this occurs. And this creation of energy is in the form of ATP, which is basically our body's form of fuel. And so where the succinate dehydrogenase complex comes into this process is within the Krebs cycle. And so the Krebs cycle basically takes sugars or amino acids and basically breaks them down and then turns them into energy. As part of this is the succinate to fumarate conversion, and this is through the succinate dehydrogenase, or SDH complex. But when there's loss of SDH through either mutations in the gene, or through, as I'll talk about, changes in the expression of the gene through changes in the DNA, we get an accumulation of succinate and a decrease or loss of the fumarate. So the succinate dehydrogenase complex, again, sits in the mitochondria, and it's a complex that's made up of multiple components. It's got the succinate dehydrogenase A, B, C, and D components that are within the inner layer of the mitochondria here, this sort of squiggly layer. And again, this complex of these proteins together, these A, B, C, and D, is what's converting succinate to fumarate. In the absence of one of these components of the pathway, or when mutations occur in one of these that leads to loss of these, the complex cannot stay together, and so therefore that leads to loss of succinate dehydrogenase B protein expression. So why it's important about talking about succinate and succinate dehydrogenase is because when this pathway gets altered, we get accumulation of succinate. And succinate is what people have termed an oncometabolite, meaning that it's a component of our metabolism, but in and of itself, it has effects that can lead to cancer formation or oncogenesis. And so with the mutations in the SDH complex, we get this accumulation of succinate, which then ultimately leads to multiple downstream steps that leads to effects upon glucose metabolism, angiogenesis, which is blood vessel formation, tumor cell motility, meaning their ability to invade and grow and spread, and then survival of tumor cells. So returning to GIST itself, we talk about SDH tumors, and beyond just GIST being associated with SDH tumors, there's also paragangliomas, which are tumors that basically arise within hormone cells that lie everywhere from the neck all the way down through sort of the backside of our abdomen and sort of the outside of the adrenal gland. They're the equivalent of what are called pheochromocytomas. These types of tumors are, whether they're pheochromocytomas or paragangliomas, often can secrete hormones such as catecholamines, such as norepinephrine, or also known as noradrenaline, or epinephrine, also known as adrenaline. So these are the hormones that are sort of when our flight or fight responses occur. When you get scared or something bad happens and your heart rate starts racing, it's the secretion of those hormones, these adrenaline hormones, that is the source of that. Well, that's normal for our survival, but these tumors, these paragangliomas, can also secrete the same tumors. Now, there's two sort of flavors of alterations in the SDH genes. One form being the Carney-Stratakis syndrome, which is associated with germline mutations, meaning that these are the hereditary mutations that are passed down from parent to child. These can occur in the A, B, C, or D genes. Most patients present with tumors, whether they're GIST, paragangliomas, or GIST and paragangliomas, often in their late teens to 30s, although I've seen patients all the way up to their 60s presenting with initial diagnosis of GIST in the setting of Carney-Stratakis syndrome. There is no sex predilection. Now, the other presentation is the Carney's triad, which is due to promoter hypermethylation. So what I mean by that is when we look at the DNA of the succinate dehydrogenase C gene, upstream of where the actual gene is itself, there's what we call methylation, or these changes, these ME groups that get put on the DNA, and they affect the ability of the DNA to be made into RNA and made into protein. And so when there's lots of these groups here, as you can see sort of by the black circles filled in, it blocks the ability of this gene to get turned on. And as I said before, in the presence of a loss of any one of these, A, B, C, or D, that whole complex falls apart. And so therefore, it's a non-functional complex. And that results in, again, loss of the succinate dehydrogenase complex and loss of the SDHB protein staining, as I previously showed you. Now, what's different about these than the carne sarcoides, ones which are hereditary, is that these are sporadic, meaning that they just come out of the blue. Nobody knows why they occur. They tend to occur in teenage females. Generally is not associated with occurring in males. And in addition to developing paragangliomas, which the carne sarcoides patients can develop, patients can also develop pulmonary chondromas, which are basically benign tumors in the lungs, as well as benign adrenal tumors, also known as adrenal adenomas. One of the unique things about the SDH tumors, and specifically GIST, and I'm going to sort of more focus on GIST from here on in, is that their pattern of spread is a little bit different than most other GISTs. In general, GIST is felt to spread through the blood, and therefore we see patients with liver tumors, or we can see also peritoneal tumors, meaning that they line the abdominal cavity, and that's more common amongst the sort of quote-unquote standard GIST, being the KIT, the PDGFR alpha, et cetera. Now, one of the differences is that the SDH-deficient GIST also can develop lymph node metastases. So it's essentially, in essence, a third mode of spread, not just blood, not just through peritoneal spread, but also through lymph node spread. So the biology of these is a little bit different than some of the other types of GISTs. And this is just some examples of when we talk about tumors. So here's a liver tumor. Here is large volume of gastric nodes and tumors around the stomach. And then here's peritoneal disease, which is basically tumors lining the abdominal cavity. So what is our problem with these patients and with SDH-deficient GIST is that these tumors are often in adolescents and young adults. They're often germline, meaning that, again, that they're spread and they can be transferred from multiple generations, and so the problem keeps getting perpetuated. And then they can spread by 3 different mechanisms rather than the 2 most common mechanisms that we see with other types of GIST. So how do we treat these tumors? So it's classically been thought that these tumors have low response rates to most drugs, or the tyrosine kinase inhibitors that we use for the GIST that we see more in the adult population, and those with the KIT and the PDGF mutations. I put together here a table showing different studies that have been published over the last 10 years or so, demonstrating response rates of the common drugs that we use for GIST in patients with SDH-deficient tumors. So you can see here the first line of therapy for patients with GIST is imatinib. You can see in this study by Boykos and colleagues from the NIH clinic that only 1 patient out of 49, or 2%, responded. This is a study from Dr. Heinrichs, published in JAMA Oncology, basically showing 1 out of 12 patients treated with imatinib responded. And this is data that we had looked at in the LifeRap database, and there was about 6 out of 41 patients that had been treated with imatinib that had some response. Nilotinib, there's within the LifeRap database, there was 1 patient out of 7 studied that had responded. Regorafenib, small numbers here. So in this study by Ben Ami, there was 2 out of 6 patients had some type of response, although granted, regorafenib is often hard to tolerate due to side effects. In the LifeRap database, there was 1 out of 9. And then if we look at Sutent, response rates are a little bit better. In the NIH clinic, there was 10% response rates. Dr. Katie Janeway had published a paper in 2009 showing about a 14% response rate, and looking in the LifeRap database, about a 35% response rate. So overall, you can see if we were going to pick a winner right now, it's sunitinib, but we're still not seeing great responses. So what other drugs have been tried? So there's been a couple other studies that have been performed over the last several years based upon understanding more about the biology of SDH-deficient GIST. The first one was a phase 2 trial of vandetanib in children and adults with wild-type gastrointestinal stromal tumors. This drug targets 3 targets: VEGF, or the vascular endothelial growth factor receptor, the EGFR, which is the epidermal growth factor receptor, and RET. This was a study basically looking at 9 patients. And of these, 2 of the 9 patients had prolonged stable disease. Now, the remainder of those patients had progression of their disease, suggesting that there was no partial or complete responses observed in this study, suggesting that at the best we saw stabilization of disease in a small fraction of patients. The next study it was the SARC-22 study, which was a multi-center study of lincitinib in pediatric and adult wild-type GIST patients. This drug targets insulin growth factor receptor 1. This is a fairly well-tolerated drug with a clinical benefit rate of 45%, meaning that there was prolonged stable disease, but there was no responses, no partial or complete responses as designated by the PR, partial response, or CR, complete response. Just as a side note, what is the definition of partial response and complete response? So according to RECIST criteria, which is the standard method that we all use to measure tumors, a partial response is considered shrinkage of a tumor by greater than 30%. Complete response means 100% complete resolution of the tumor. Progression of disease means greater than 20% growth of a tumor. And so therefore, anything between 29% response and 19% growth all counts as stable disease. So it's basically half of that spectrum is stable disease. So what are some other trials that are going on? There's a glutaminase inhibitor trial that's being performed. I'm unaware of the dates of the reporting of data at this point. This is targeting metabolism itself. And then, as many of you know, there's a trial at the NIH. I'm using a DNA methylase transferase inhibitor, or guadocytabine, which is targeting that methylation process I was showing with the Carney triad patients in that picture, which basically is being used to target patients with wild-type GIST, pheochromocytoma, or paraganglioma associated with SDH deficiency. And again, those data have not been reported publicly. So what about non-tyrosine kinase inhibitor therapies or non-methylation transferase inhibitor drugs? So one of the other drugs is temozolomide. Temozolomide is basically a drug that works to also affect the DNA. It's a drug that's absorbed and basically gets converted to a subsequent metabolite called MTIC. This then travels to the nucleus and then binds to the DNA, leading to cell death or apoptosis, which is programmed cell death. Now, there's been 2 studies looking at temozolomide in patients with GIST. These were both performed in the early 2000s, well before we understood the biology of SDH-deficient GIST. Most of the patients were older. While there was stabilization of disease in some patients, there was 0 objective responses seen, or the objective response rate, meaning that there was no partial responses or complete responses seen in these 2 studies, each one being 18 patients. Now, why do we think that potentially there may be a role for temozolomide in SDH-deficient patients? Is if we go back and look, there was a retrospective study, meaning a study that looked back on patients with paraganglioma in France. They looked at 15 patients that had paraganglioma, and of those 15 patients, they dichotomized them whether they had SDH mutant tumors or they had SDH wild-type tumors. And you can see here, of those patients, the 5 patients that had SDH wild-type tumors, 5 of those patients, none of them responded to temozolomide treatment. However, if we look at the patients that had SDHB mutations, half of those patients had some type of objective response based upon imaging. And that led us to suggest that perhaps temozolomide might be something that's a viable option for thinking about treating patients with SDH-deficient GIST. So does this work in GIST? So right now, the state of the field for SDH research in GIST includes thinking about how we use cell lines, animal models, human or fresh tumors, and potentially using computers or in silico bioinformatics. And this is sort of the standard way that we think about developing models. So what do we have for SDH-deficient GIST? So these are some studies that have been published over the last several years looking at just the models that are available right now for SDH research. So this was a study that was published by Eyal Gottlieb's group, who he's in now in Israel, but was previously in Scotland, using an SDH-B deficient kidney mouse cell line. So is SDH deficient, but then may not necessarily replicate the biology of GIST since it's a kidney tumor. This was another study basically looking at immortalized, meaning that the cells that will perpetually grow, looking at, again, another type of mouse neuroendocrine cell. This study was a study published actually from UC San Diego looking at SDH-deficient Chinese hamster fibroblasts, so not cancer cells, but fibroblasts that were immortalized. Interestingly, these cells, this paper was actually published in 1977 out of UC San Diego, and the senior author on it is still actually here on faculty. The next study is a study that was published out of Arthur Tischler's group. This is really the first time that an SDH-deficient GIST tumor line was grown. This was funded by the For Ian project. The one caveat to the cell line, which is very different than the biology of most patients with SDH-deficient GIST, is that there was a KRAS mutation within this, which makes the biology of these tumors significantly different than the usual standard SDH-deficient tumors that lack KRAS mutations. And KRAS is another oncogene, which is very aggressive and very common in many types of cancers. Looking at mouse models, this is as a mouse model of GIST, or excuse me, of SDH-B loss. So when you sort of put a word cloud together, what are we talking about? What is the state of the art right now? So we're limited really to mostly in vitro, meaning in culture models, and then a mouse model of SDH-deficient tumors. But there's very little models of human tumors for this disease. So the first thing we set out to determine was, could we develop a better model of SDH-deficient GIST for preclinical modeling and preclinical translational research? And this is where it's important to sort of think about marrying the clinical side with the basic research side. And as Sarah mentioned, not only am I a surgeon, but I've also got a research laboratory that studies GIST, so we can remove tumors and then immediately bring them over to my laboratory and work on trying to culture those cells. So in our experience here, about half of our patients are SDH-B deficient, or SDH-B mutant, and we've got a handful of A's, B's, A's, C's, and D's. I probably need to update this slide also with Carney triad patients. So I was lucky enough to hire a super smart PhD by the name of Dr. Myra Yoruba a couple years ago. And Myra was able to figure out a way to take tumors, SDH-A, B, or C tumors, and grow them in cultures, in Petri dishes, or in vitro as we would call it. And she's been able to grow these in multiple different fashions, whether just on plastic, whether in three-dimensional cultures, whether in cultures that are replicating the biology of three-dimensional growth in matrices. And in all of these settings, what Myra has been able to show is that she can grow these cells and that these cells maintain expression of the standard markers of GIST, being the KIT and DOG1, as I mentioned earlier. So the blue here is the nuclei staining of these cells. The red is KIT. The green is DOG1. And anywhere where there's sort of a yellowish color is the overlapping between the green and the red, meaning that the cells are simultaneously expressing both markers at the same location. And if we take this further, we can do protein analysis, and we can basically show that as opposed to our KIT mutant cell lines, GIST-T1 and GIST-882, which are very commonly used GIST cell lines that are sort of the workhorses in the field, that our tumor cells lack or have very low expression of SDHB protein expression as compared to our KIT mutant tumors. Moreover, when we do RNA analysis, we can compare on the y-axis the cell lines as opposed to the actual human tumor that the cells were derived from. And you can see here that we look to see if there's a correlation between the tumors and the cells. And essentially a correlation of 1, and this R-squared value is a perfect 100% correlation. So what this data suggests is that we're anywhere between about a 93 to about a 95% or 94% correlation between our cells and the original tumors that they were derived from based upon expression analysis. In collaboration with Mike Heinrich and Chris Corliss, we've gone on to sequence these cells, and we confirm that they have the exact same mutations in the cells that the tumors had, whether they're A, B, or C. Using data that's been published in other series from other groups, from what have been described as signatures of SDH-deficient tumors, whether we look here within Pantaleo's group, Lorilot, Cervera, or KEG, which is basically pathway analyses, we find that there's a high correlation between the expression patterns that we see in our cells versus what's been reported as markers of expression of SDH tumors. You can see here things are color-coded down here, that we tend to find that we're anywhere between moderate to very strong correlations with the previously described signatures of SDH-deficient tumors. Now, we were lucky enough to have a collaborator here on campus by the name of Christian Metallo. Dr. Metallo is a PhD whose laboratory works on studying metabolism, and so we've gone on to take the cells that we've grown from these tumors to look at the actual succinate and fumarate levels within the tumor cells that have been derived from patients with SDH-deficient tumors. And what you can see here, this is the ratio of succinate to fumarate. In patients with in patients with tumors or with cell lines that have normal succinate dehydrogenase, the ratio should actually favor fumarate because succinate is being converted to fumarate. But when succinate is lost, we should have an accumulation of succinate and a loss of fumarate, meaning that the ratio is higher of succinate to fumarate. And what you can see here, here's the ratio of cells that are wild type for SDH versus SDH-A, B, and C mutant cells. You can see an increase in the amount of the ratio of succinate to fumarate, suggesting that succinate is accumulating. So to summarize what we've done in our laboratory so far, we've developed an approach for growing SDH-deficient cell lines. We've been able to grow, as of to date, SDH-A, B, and C mutant cells in culture. We don't have Cs, not because they haven't been able to grow, or correction, Ds, not because they haven't been able to grow, it's because we haven't had access to those cells as of yet, nor Carney triad cells. But if anybody is interested in having their tumor tissue sent to us, we would be happy to attempt to grow their cells in culture. The one caveat is this needs to be tissue that is immediately obtained from the operating room and either specially frozen in a manner that allows the cells to be resuscitated and grown again, or needs to be directly taken straight from the operating room and put into a culture dish. We can't use old cells from years ago that are sitting around. It's not possible to grow those. We show that these cells can form three-dimensional colonies, which is consistent with tumor cell growth. We show that these cells generally lack the SDH-B protein expression that we would expect that SDH-B deficient cells would have. We show that these cells express the classic markers of GIST, being KIT and DOG1, and that through next-generation sequencing analyses, whether it's RNA or DNA, that these are very similar cell populations to the primary tumors that they were derived from. And finally, we show that the Krebs cycle metabolism is altered in these cells with elevated succinate to fumarate ratio, suggesting that the metabolic defect that we would expect these cells to have is present. So based upon knowing this, we had a hypothesis, and we hypothesized that SDH-deficient GIST and other SDH-deficient tumors share a common molecular phenotype and sensitivity to temozolomide. So what we see here is what we call our cell viability killing curves. And the way these work is that on the y-axis is the cell viability, so 0 to 100, and on the x-axis is increasing dosage of drugs, and this is on a log scale. So what we do is an 11-point dose response curve where we treat the cells with a drug in increasing concentrations. And what we'd expect for a drug that is sensitive is that early on we sort of see a dip down in the curve, as you can see on the right side, versus cells that are resistant only really at the highest doses when you just overwhelm the cells with super physiologic concentrations of the drug will we see killing. So on the left side here, you can see that the SDH cells are grown in the presence of sunitinib, and that we generally see resistance to the drug except at the highest doses, versus when we treat the cells with temozolomide, we see increased sensitivity, and we can see that we can essentially bring these all the way down to almost 0% of cells alive all the way the highest half of the doses, as opposed to, you can see here, the highest half of the doses are still anywhere between 30 to about 90% of cells still alive, with the exception of the highest dose, which is beyond what can be administered to a person. Now, the next question becomes, is the drug working the way we would expect it to work? So this is what we call COMET assays. The way COMET assays work is anytime there's damage to the DNA in a cell, the DNA sort of fragments, and so we can look at the fragmentation of the DNA, and the longer the tails are on these comets, if you will, the more suggestive of DNA damage there is. And so the examples of normal versus temozolomide-treated cells are here on the bottom, and these are the actual lengths of the tails. So the longer tails seen with temozolomide treatment, suggesting that the mechanism by which temozolomide is working is increasing DNA damage. So does this work? Well, as many of you know, within the SDH community, we're running out of treatment options for patients. And so on some histology independent protocols that we had here at UC San Diego, we had a few patients where we were rapidly running out of treatment options and had really very little where to go. And this is a patient that had been treated with imatinib and sunitinib and had very rapid progression of a disease on regorafenib. And so with little options left, and based upon some of the biology that we knew from our laboratory, we put him on temozolomide, and you can see here after 8 months, you can see here a pretty significant shrinkage of this tumor here in the liver down to this smaller lesion here, suggesting that we are seeing a partial response of temozolomide in patients with in a patient with an SDH-deficient tumor. This is a PET scan of another patient that had progressed on imatinib and sunitinib and elected to forego regorafenib. He had extremely extensive disease. This is a snippet of normal colon here. All these little sort of bubbles, dots here are all metastatic GIST. You can see on the left side here, his PET scan, all these dark spots are all tumors lighting up. So we put him on temozolomide, and you can see here after just 2 months, you can see here a pretty tremendous decrease in the amount of uptake on the PET scan. It's not 100% gone, but you can see here just as a couple of examples that I highlight with the arrows, but there's certainly a lot of other lesions that I don't highlight that also are responding. That you can see just as a general 30,000-foot view that there's a tremendous response of the patient's tumors to temozolomide treatment. So based upon this, we went on to treat a handful of patients that had failed other lines of therapy, with the exception of one patient that had elected to forego other treatments. In the first, the way this is called a waterfall plot. So the way this works is basically looks at the response rates of patients. So as I mentioned before, the responses are based upon measurements of the tumors. The way this works is that anything that is a shrinkage of the tumor is a downward reflection. Anything that's growth of a tumor is an upward reflection on the y-axis. The partial response is a cutoff of 30%, meaning that anything between here that's greater than, anything that's between 0 to 29% is considered stable disease, and anything between 0 to 20% growth is considered stable disease. So this whole portion here. Anything that's greater than 30% response is considered a partial response, and anything that's greater than 20% growth is considered progressive disease. And what you can see here is that 2 of the patients had nice partial responses to treatment. The 3 other patients that had stable disease had either small amount of shrinkage or minimal amount of growth, and in all 3 of those patients, they had been previously progressing on their prior lines of therapy, or in the case of the one patient that had not undergone previous therapy, that tumor had been progressing in the absence of treatment, and we created stabilization of her disease with treatment with temozolomide, suggesting that there was an early signal that the temozolomide may be working in patients with SDH-deficient GIST. So based upon this, we would consider this a 40% response rate, meaning 40% of patients had some type of tumor shrinkage by RECIST being greater than 30%, and that 100% of patients had some type of clinical benefit in terms of disease control. So just to summarize what our data is to date, we've developed an SDH-deficient GIST program here at UC San Diego, allowing us to collect tissue and develop novel SDH-deficient GIST cell lines. We've been able to show that SDH-deficient GIST are sensitive to temozolomide in culture, or meaning in vitro, and that in a small subset of patients that we've been able to treat these patients and able to see responses. And so where have we taken this is developing a formal clinical trial to study temozolomide for patients with SDH-deficient GIST. This protocol was developed in 2018. At that time, we applied to the FDA for an investigational drug exemption, IND approval for the drug to be used here. We opened the trial up to accrual last year in August 2018. We subsequently enrolled the first patient a month later. We got a small amount of pilot funding to open the trial through our UC San Diego Cancer Center Pedal the Cause, which is a fundraiser that's done every year through our cancer center to raise funds for pilot projects with the goal of trying to get these projects off the ground to get additional funding. And then I'm actually excited to announce that as of yesterday morning, I woke up to an email telling me that we had received a formal grant from the FDA to further fund this trial to allow us to then be able to bring this to sites outside of UC San Diego. And so right now I am working with centers essentially around the country at sites where SDH patients are commonly seen in order to work to open the trial on both coasts and both north and south. And so this way more patients will have access to the trial and potential treatment for their SDH-deficient tumors. This trial is being done, I should mention that Adam Burgoyne, who is one of our medical oncology faculty, and I put this trial together as a team, and Adam is running the trial as the principal investigator of the clinical side of the trial. So the way the trial is designed, we will obtain a consent. We will screen patients to confirm that they are SDH either mutant or deficient, whether they're, this includes both Carney-Strataka syndrome patients and Carney-Triad patients. Patients are treated with temozolomide for 3 weeks on and 1 week off, so basically every 4 weeks or every 28 days is considered a cycle. The nice thing about this drug is that it's orally administered, meaning that it's taken by mouth. As part of the trial, we're obtaining scans every 2 months to follow, and we're basically continuing treatment until either progression of disease or until unacceptable toxicities. The primary objective of the study is to determine the overall response rate at 6 months for patients with SDH-deficient tumors. And so as I described before, we're looking at partial responses and complete responses via RECIST criteria. Our secondary objectives are to determine the progression-free survival and the overall survival, as well as the safety and tolerability of temozolomide in patients. As an exploratory aims, we're looking at the effects of temozolomide on succinate and fumarate levels in the blood. So there will be blood draws associated with this, and we're investigating the effect of temozolomide therapy on tumor metabolism in patients where they subsequently undergo operation following treatment with temozolomide, or if they undergo biopsy of their tumors. The key eligibility criteria, so basically it's patients with pathologically confirmed GIST that have loss of SDHB protein expression by immunohistochemistry. They have to have SDH A, B, C, and D gene mutation analyses. As of right now, the trial is written such that the patients need to be 18 years or older, because at our center we only see 18 and above in general, although if we are going to be able to open this up at other sites, as we now should be able to do with this additional funding, we're going to work to see if we can decrease the age range for this so that some younger patients can be enrolled as well. Other eligibility criteria, including recovering from any other prior chemotherapy, immunotherapy, or radiation therapy, and that they cannot have had operations within 4 weeks of study drug, which is generally not a problem, as we can always wait a couple extra weeks and get outside of that window. Our target accrual is 23 patients with a study length goal of 4 years. What are the most common side effects? So in general, from my experience seeing these patients, the most common side effects are nausea, a little bit of vomiting, loss of appetite, and fatigue are the most common things that we see. But you can see here, as excuse me, seen with lots of other chemotherapy agents, you can see some diarrhea, dizziness, weakness, some insomnia, some low blood counts, and some hair loss, although I've not seen patients lose all of their hair at any point during the treatment of any one of these patients. So to summarize, I think we've come a fair bit of way in the last couple of years with developing models for SDH-deficient GIST, and we're still working to refine this and identify better treatments for GIST. Temozolomide is our next step in this process, but it's not stopping there. We're continuing to investigate whether there are other drugs that we can use in the future as either in combination with temozolomide or as separate regimens. This work has not been done without a huge team of people. I want to highlight Myra Yerba from my laboratory, who has done a lot of the in vitro cell line work. And on the clinical side, Adam Burgoyne, who's the principal investigator of the trial, as well as Dr. Paul Fanta, who's another one of our SDH-GIST medical oncologists here at UC San Diego, who's seen a lot of the SDH patients in the past, as well as our clinical trials coordinators and our collaborators at OHSU and Sanford Burnham Prebys. And finally, most importantly, I want to thank our patients and the families for trusting us and allowing us to care for them with this difficult disease. And this work couldn't be done without the support of many groups. I just want to point out a couple of key groups that have been critical to moving our SDH GIST work forward. First being lighting the path forward for GIST cancer research. In addition, the SDH-deficient GIST research advocates, and then finally the LifeRAF group. And with that, I will stop, and I am happy to answer any questions. And thank you very much.
Thank you, Dr. Sicklick. Great presentation. All right, so we have a few questions. First question, you mentioned regorafenib and difficulties tolerating the drug. I'm 47, based in the UK, wild-type SDH-deficient GIST, and have been on regorafenib 120 milligrams for 4.5 years. I've been following a low food map diet and changed to lactose-free dairy milk. This has really helped me manage the side effects. I also exercise regularly. Have there been any studies into diet and exercise to see if this helps treatments to be more effective?
It's a great question. I mean, I think across the board, we know that there's been, I think the biggest patient population where diet and exercise have been studied is in the breast cancer population. You can correct me if I'm wrong, but I'm unaware of any data in the GIST population about a specific diet and or exercise regimens that are associated with decreasing GIST recurrence. But within the breast cancer field, there's been several studies showing that, not surprisingly, that exercise is good for you, and exercise decreases your risk of disease recurrence. And then I believe that some similar findings have been shown with diet as well. I mean, in general, I think a well-balanced, healthy diet as well as exercise is probably critical to any disease in terms of keeping your immune system in check and keeping your body healthy.
Okay, thank you. Next question. Do you expect this trial to extend to the NIH, and if yes, by when?
Right now, I don't know the answer to that question. The NIH is running their own trial, and so at this point, I don't know the answer to that question.
Okay. The next question is, do you know if Notch mutations are common with SDH-deficient GIST?
I am unaware of that. I know that we have seen Notch pathway mutations more frequently with the NF1 mutant GIST, but I have not seen any association in our experience at this point with SDH-deficient tumors, but there's certainly potential there.
Okay. How many total patients have you had in the trial? Is it only the 5 that you showed? If it is more, what has the response been in total?
So, so we've treated the 5 patients that I showed you were treated prior to the actual formal trial opening up. To date, we've enrolled 3 trials. As with any trial, we can't disclose the response data at this point until the final trial has been completed.
Okay. What kind of progression or prognosis would you not recommend enrollment in this trial? Should only really bad prognosis enroll, or anyone?
I mean, I think it's, the trial is open to anyone. I would say just in general, as a sort of rule of thumb amongst any disease, if we've got it, when we have an effective therapy, in general, most effective therapies tend to work earlier in the disease biology than they do later. The later we try to, as I described, sort of turning the tanker ship around, it's much more difficult to make a tanker ship turn around than it is trying to treat the disease earlier in the disease biology, and when fewer resistance mechanisms to the disease have occurred, fewer new mutations in genes have occurred, all these different potential things that confound responses. Waiting till somebody is incredibly sick and has incredibly extensive disease, the likelihood of any drug at this point working for most diseases, with a few exceptions, and perhaps the KIT mutant GIST were obviously a good example of that back in the late 90s, early 2000s when imatinib came about, is that it's preferable to treat patients earlier on. I'm not advocating if somebody's got a solitary tumor and doesn't have any metastatic disease, that may not be the case, or if they've got very stable indolent disease, that may not be necessary to treat them at this point. But for those patients that have progressive disease, that it might be appropriate to consider. But it would certainly be a discussion that would have to be on a patient-by-patient basis.
Just as a follow-up to that, which kind of overlaps with another person's question, is how do you make that choice between surgery or the trial? Because surgery seems to be a common treatment for this disease, right?
Right. So I think, as with all GIST, surgical treatment is the potentially most definitive treatment for GIST. Period. More than even for KIT mutant GIST. Imatinib does not cure KIT mutant GIST either. So surgery is the only true potential for curing the disease. I think in terms of resection, there are differing opinions about when a resection is appropriate for patients with SDH-deficient GIST. I think we can all agree on the fact that when patients are either bleeding, obstructed, they have a perforation, meaning a hole in the bowels, or having significant symptoms or pain secondary to their tumors, that if their disease is resectable, that palliative operation to treat these symptoms, is a reasonable approach. The other potential scenario that is a little bit more on the controversial, depending upon who you talk to, would be in patients with well-controlled disease, with a limited amount of disease that's non-progressive, would be consideration of resecting all visible disease in order to essentially cytoreduce somebody down to no evidence of disease. And that's a little bit more on the controversial side. We do know from on the KIT side that is becoming more and more accepted, but that it's not fully accepted within the SDH community.
Thank you. Okay, next question. Have you looked at the amino acid mutation detail? There are variations below SDHX, for example, SDHC R133. how does the mutation detail impact the treatment and thoughts on this trial or others?
I think at we don't have enough information on that at this point. I mean, our numbers are still small. I can't, and the potential for there's so many different mutations within. We're talking about 4 different genes, A, B, C, and D, which all, there might be subtle differences that we don't appreciate between A's, B's, C's, and D's, as well as between carny triad and carny Stokes patients, and that there are potential, numerous different mutations that can cause loss. I don't have an answer in terms of individual mutations that might portend more sensitivity and or more resistance at this point. I think that's one of the things that we will learn from doing a trial. As much as we all want to just get the answer right now and have an answer and say this works or doesn't work, the only way to keep moving this field forward is to continue working and trying to learn. And while we wish, I wish we had a drug that was unanimously 100%, just completely causing all disease to disappear, we need to keep working on that. But for right now, we need to, in the meantime, we need to be thoughtful and continue to learn about how we can, treat this better.
Okay. I think you might have mentioned this before, but a question came in about what side effects have been observed so far.
Yeah, I'll go back to that. Hang on. So here's I show there the most common side effects in patients. The biggest ones generally are nausea and vomiting, loss of appetite, fatigue. Those are the biggest things that we generally see, and fatigue is probably the worst. And it's not that it's immediate, it's cumulative over time that people tend to get more and more fatigued is the most common thing we see.
Please stay.